Principal, SGS Ankli.
Dr. Pankaja Savanur, Organizing Secretary, HOD, Department of Kaya Chikitsa, and Dr. Vishal Chowgle, Organizing Secretary, HOD, Department of Panchakarma. Now I request Dr. Pankaja Savanur, Organizing Secretary and HOD, Department of Kaya Chikitsa, to welcome today's chief guest, Shri Subhash Sampagavi, Assistant Commissioner, Chikodi. Next, I request Madam to welcome Dr. N.A. Magdum Sir, President, SGS Ankli. Next, I request to welcome Shri S.B. Chowgle, Secretary, SGS Ankli.
Now I request Dr. Vishal Chowgule, Organizing Secretary, Head of the Department, Department of Panchakarma, to welcome Dr. Sujay A. Kulkarni, MD Medicine, DNB, Gastroenterology, Miraj. Dr. Ashok Kulkarni, MD Medicine, renowned practitioner from Miraj. Dr. Vinay Mohan, Principal, Inchal College. Dr. Basavaraj Y. Ganti, Principal, Harugiri College. Please welcome our Principal, Dr. Prasanna V. Saunur, sir. Vice Principal, Dr. N.A. Magdum Ayurvedic Medical College, Ankli. Now may I request Dr. Seema to welcome today's organizing secretaries, Dr. Pankaja Saunur, Madam. She is Head of the Department, Department of Kaya Chikitsa. And welcome Dr. Vishal Chowgule, Head of the Department, Department of Panchakarma. He is also an organizing secretary of today's function. Thank you, Seema, Madam. Now I would like to invite our organizing secretary and head of the department, Department of Panchakarma, Dr. Vishal Chowgule, sir, to welcome the gathering.
Good morning, everyone. Respected dignitaries, today's chief guest, Sri Subhash Samgavi sir, Assistant Commissioner, Chikodi, our beloved Dr. N.A. Magdum sir, Chairman, Sri Gomtesh Education Society, Ankli, respected Sri Suresh Chowgule sir, today's speaker, Dr. Kulkarni sir, Principal sir, Vice Principal sir, and Dr. Saunur madam, and here present Dr. Vinay Mohan sir and Ganti sir. I welcome you all to the Yakrit Sanjeevini National Conference on Integrated Approach on Liver Disorders organized by Department of Kaya Chikitsa and Panchakarma. I would like to extend a special welcome to our principals, then media persons, esteemed faculty, practitioners, students who have traveled from across the country, including Karnataka, Maharashtra, Gujarat, Kerala, Madhya Pradesh. Your presence enrich our gathering and underscore the significance of the topic. With this, I wish you all a rich and rewarding experience at the Yakrit Sanjeevini conference. Soak the knowledge of feast, engage in meaningful discussion, and enjoy the conference. Thank you, one and all. Thank you.
Thank you, sir. Let's begin this special event by invoking the blessings of Almighty. I invite Shrutika and team for the Gomatesha Stuti.
विसट्टकन्दट्टदलानुयारं सुलोयनं चन्द समानतुण्डं घोणाजियं चम्पय पुप्पसोऽहं तं गोमटेशं प्रणमामि नित्यं तं गोमटेशं प्रणमामि नित्यम् अच्छाय सच्छं जलकन्तगण्डम् आबाहुदोलन्त सुकर्णपासम् गैन्द्रसुण्डुज्जल बाहुदण्डम् तं गोमटेशं प्रणमामि नित्यम् तं गोमटेशं प्रणमामि नित्यम् सुकण्ठसोहाजियदिव्यशङ्खं मालयुद्धाम विशालकन्धं सुपेखनिजायल सुट्टुमध्यं तं गोमटेशं प्रणमामि नित्यम् तं गोमटेशं प्रणमामि नित्यम् विचायलग्गे पविभासमानं सिंहामणि सौव सुचेदियानं तिलोय सन्तोषय पुण्यचन्दं तं गोमटेशं प्रणमामि नित्यम् तं गोमटेशं प्रणमामि नित्यम् प्रणमामि नित्यम्.
Thank you, students, for a vibrant start.
Agni Purana says, Deepena lokan jayati, deepas tejo mayah sprutaha, chaturvarga prado deepaha, tasma deepair jayat shriye. One wins the word through lamp. Lamp is full of glory. It provides all the fruits of dharma, artha, kama and moksha. So one should worship with a lamp for shreyas, that is prosperity. I request all the dignitaries on the dais to come forward for Dhanvantari Pujan and lamp lighting. I request Miss Aishwarya for Dhanvantari prayer.
नमामि धन्वन्तरीरादिदेवं सुरासुरवन्दितपादपद्मं लोके जरारो भयमृत्योर्नाशम् धातारमीशं विविधौषधीनां शङ्खं चक्रं जलौकां धदतमृतकटं चारुदोधिष्वतुर्भिः सूक्ष्मस्वच्छां विरुद्धम् शुकर परिविलसन् मौलिमं भोजनेत्रं कालाम्भोदोज्ज्वलाङ्गं कटितटविलसच्चारु पीताम्बराढ्यं वन्दे धन्वन्तरियुतं निखिलगदवन प्रौढदावाग्निनिलं प्रौढदावाग्निनिलं प्रौढदावाग्निनिलम्.
Thank you all. Now I would like to invite Dr. Prasanna Savanur, Principal, Dr. N.A. Magdum Ayurvedic Medical College, Hospital and PG Center, Ankli, to deliver the keynote address.
A very good morning to one and all. A very respectful, Honorable Assistant Commissioner, Sir, Sri Sampagami Sir, and I can say my mentor and the chairman of the institution, Dr. N.A. Mugdum Sir, and the secretary, Dr. Suresh Sogle Sir, and the senior most. See the occasion, I don't know what is the relation between me and Ashok Kulkarni sir. Whenever I used to have any occasions, I used to have his blessings always, because on the day of my joining also, his blessings I took, and today also for starting this conference, his blessings I am seeking. Today's one of the speakers, Dr. Sujay Kulkarni, and my friends, Dr. Vinay Mohan, Dr. Ganti, and young and energetic, the Vice Principal of this institution, Dr. Ramgonda, and the organizing secretaries, Dr. Vishal and Dr. Pankaja, and my dear colleagues and dearest students from across the country. So today's this event, a warm welcome to all of you. This Yakrit Sanjeevini, this national level conference, that's a seminar or a conference on integrative approach towards liver disorders. Why this theme? Theme of seminar is not only for what you can say conducting any seminar or other things for only timely, but also a vital importance is there for this one, as we face increasing burden on hepatic disorders in both developed and developing countries. I think this in detail it will be dealt. The importance of this liver, that what we come across as not merely a vital organ, but it's also a marmasthana according to Ayurveda. Okay, a seat of life and vitality. In classical texts, it is linked with Raktavaha Shrotas, Pittadara Kala, and Yakrit in Pliha. Our ancient acharyas, I'm not going to take in detail because you are going to study in detail in this. It is told that this multifaceted role of this liver in metabolism, detoxification, and immune balance centuries before the modern hepatology evolved. So why this integrative approach at this moment? Today, this liver disorders span from fatty liver diseases, hepatitis, cirrhosis to autoimmune and drug-induced liver injuries, and many more. While modern medicine offers critical life-saving interventions, it often faces limitations in long-term management and holistic care. This can contribute not only an alternative, but as an complementary and integrative system. So an integrative approach strengthens of Ayurveda as well as modern science with dosha vikriti diagnosis, bheshaja, that is formulations, ahara, that is lifestyle, diet lifestyle, which can be provided through Ayurvedic sciences, panchakarma therapies, where we can go with the detoxifications, along with this biomedical diagnostic and monitoring. This model not only enhances clinical outcomes, but also gives WHO strategy for incorporating traditional system into mainstream of healthcare. So what would be our responsibilities when we go for this? Because only conducting a conference on some of these topics may not be sufficient, but we should have our own responsibilities as an Ayurvedic fraternity. This Yakrit Sanjeevini, this conference is conducted. It's a platform of collaboration between the clinicians, academicians, researchers, and some of the policy makers, those who are listening. It is also called deepen our understanding of liver disorders from both classical Ayurvedic literature and contemporary evidence-based research. So let us revisit Ayurvedic classics with a translational mindset, documented clinical outcomes through standardized protocols, promote inter-system dialogues rather than dialogues, innovative dosage forms, and delivery mechanisms for classical drugs like Bhumamalaki, Katuki, and so many classical drugs are available, and strengthen the pharmacovigilance and safety profiles of traditional hepatoprotectives. The way forward must also include collaboration with biochemistry, pharmacology, and modern hepatology departments to bring integrative liver care into an academic curricula and institutional frameworks. So this should be the aim of our conference. So to conclude, before concluding, I extend my heartfelt appreciation to the organizing team who has taken all these efforts to bring this seminar with such a depth and relevance of this topic. So I also congratulate all the presenters, those who are going to present, and participants, those who have gathered together from all over the country with a unified vision to protect and preserve liver health care through Ayurveda and integration. Let Yakrit Sanjeevini be the spark that lights many new paths of integrative healing. May the wisdom of Ayurveda continue to enrich global health, and may we remain torchbearers of science that is both ancient and ever evolving. Thank you one and all. Dhanyawad. Jai Hind. Jai Karnataka. Thank you.
Thank you, sir, for this beautiful keynote address. Now we have reached the milestone of this inaugural function. So we are grabbing an opportunity when we saw this huge gathering. It gives us an immense pleasure and joy to bring a multi-author exploration of holistic healing named Ayurveda Perspective Research Chronicle, a thoughtful and timely contribution to the ever-evolving field of Ayurvedic science. This multi-author volume is a tribute to the enduring wisdom of Ayurveda, presented with a research-oriented lens that bridges tradition and contemporary sciences. Now may I request all the dignitaries on the dais to please join your hands for a book release named A Multi-Author Exploration of Holistic Healing, Ayurveda Perspective Research Chronicles. In an era where the global health landscape is increasingly learning towards integrative and preventive models of care, Ayurveda, the ancient science of life, continues to offer profound insights into holistic healing.
This volume is a collaborative effort by multiple authors who come from diverse backgrounds: academicians, clinicians, researchers, and thought leaders. Each contributed their unique perspective on how Ayurvedic knowledge systems can be interpreted, applied, and expanded through research. The book reflects not only intellectual rigor, but also the sincere commitment of each contributor to preserve the integrity of classical Ayurveda while embracing scientific inquiry and innovation.
Under the able guidance of Dr. N.A. Magdum and Srimati Lalita N. Magdum Madam, Scientific Research Committee was formed. The responsibility of Chief Editor was successfully carried out by our dynamic principal, Dr. Prasanna Savanur sir, and Dr. Vishal Chaugule, Organizing Secretary, Head of the Department of Panchakarma, is a co-editor of this book. Whole Scientific Research Committee has worked tirelessly to bring this edition.
In the future, the Institute has planned intramural research projects for the students and the faculties, totally funded by the management and present. Delegates can take this opportunity to develop their research orientation. Our principal desk will be intimating in this regard when and where.
Thank you, all the dignitaries. Now may I request today's president, even principal and vice principal sir and organizing secretaries to give felicitation to our chief guest who is here in front of us.
Shri Subhash Sampagavi, Assistant Commissioner, Chikkodi.
Subhash Sudhakar Sampagavi. He is a yoga expert dedicated to keep the health very fit by doing the yoga. He has received the Best Electoral Registration Officer 2024. Professional life, he joined the duty in 1991, first as Divisional Assistant in Sindhgi, then established caseworker in the Mahila University, Vijaypura, promoted Tahsildar Grade 1, Hundgund, Bagalkot, also served as Tahsildar in Baswan Bagewadi and Chikkodi, then promoted to Assistant Commissioner Cadre, served as a Special Land Acquisition Officer, Hippargi Project Athani, presently working as Assistant Commissioner, Subdivisional Magistrate, Chikkodi. We also take opportunity to do a felicitation to Dr. Vinay Mohan sir. He is a principal, Shri Shiva Yogeshwara Rural Ayurvedic Medical College, Inchal. I request principal, vice principal and management to give a felicitation to Dr. Vinay Mohan sir. Thank you, sir. It's our pleasure to extend our felicitation to another guest of today's function, Dr. B.Y. Ganti, sir. He is a principal of Shri Siddhivinayaka Rural Ayurvedic Medical College, Harugeri. I request principals, vice principal and management to extend the felicitation to Dr. B.Y. Ganti. Thank you. We have another special guest today. There is a quote in Sanskrit called as Putrat Ichet Parajaya. So we have a speaker of first scientific session, Dr. Sujay Kulkarni. His father we have with us. He is also a renowned practitioner in mirrors, Dr. Ashok Kulkarni. Please accept our felicitations, sir. We are very much happy to have you in this inaugural function of Yakrit Sanjeevini 2025. Thank you all the guests for accepting our felicitation, and thank you to all the dignitaries for joining your hands in felicitation. Thank you.
Now I request our chief guest, of the Yakrit Sanjeevini 2025, that is Shri Subhash Sampagavi, Assistant Commissioner Chikodi, to address the convention.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಇವತ್ತಿನ ದಿವಸ ಯಕೃತ ಸಂಜೀವಿನಿ ನ್ಯಾಷನಲ್ ಕಾನ್ಫರೆನ್ಸ್ inaugurated, approaching the liver disorders ಕಾರ್ಯಕ್ರಮ ಡಾಕ್ಟರ್ NM ಮಗ್ದುಮ್ ಆಯುರ್ವೇದಿಕ ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿ ಜರುಗ್ತಾ ಇರೋದು ಕೇಳಿದರೆ ಅತ್ಯಂತ ಸಂತೋಷದಾಯಕವಾದಂತಹ ಸಮಾರಂಭ. ಈ ಸಮಾರಂಭದಲ್ಲಿ ಯಕೃತ ಸಂಜೀವಿನಿ 2025 ವೇದಿಕೆಯ ಮೇಲಿರ್ತಕ್ಕಂತಹ ಶ್ರೀಯುತ LN ಮಗ್ದುಮ್ ಅವರೇ ಮತ್ತು ಡಾಕ್ಟರ್ HN ಮಗ್ದುಮ್ದವರೇ ಮತ್ತು SB ಚೌಗಲ ಅವರೇ ಹಾಗೂ ಡಾಕ್ಟರ್ NA ಮಗ್ದುಮ್ದವರೇ ಮತ್ತು ಪ್ರಸನ್ನ ಸವಣೂರವರೇ ಹಾಗೂ ಪಂಕಜ ಸವಣೂರವರೇ, ಡಾಕ್ಟರ್ ವಿಶಾಲ್ ಚೌಗಲ ಅವರೇ ಹಾಗೂ ಶ್ರೀಯುತ ಗಂಟಿ ಅವರೇ ಮತ್ತು ವಿವಿಧ ಗಣ್ಯಮಾನ್ಯವರೇ ಮತ್ತು ಇಲ್ಲಿರ್ತಕ್ಕಂತಹ ಕಾನ್ಫರೆನ್ಸ್ಗೆ ಆಗಮಿಸಿರುವಂತಹ ಎಲ್ಲ ವೈದ್ಯಾಧಿಕಾರಿಗಳೇ, ಈ ಆಯುರ್ವೇದಿಕ ಚಿಕಿತ್ಸೆ ಅತ್ಯಂತ ಮಹತ್ವವಾದಂಥದ್ದು. ಪುರಾತನದಿಂದಲೂ ಬಂದಂತಹ ಒಂದು ಚಿಕಿತ್ಸೆ, ಧನ್ವಂತರಿಯಿಂದ ಆಗಮಿಸಿರುವಂಥ ಆಯುರ್ವೇದಿಕ ಚಿಕಿತ್ಸೆ ಇವತ್ತಿನ ದಿನದಲ್ಲಿ ಅಲೋಪತಿಕ್ ಆಯಿತು. ಇನ್ನಿತರ ಚಿಕಿತ್ಸೆಗಳಲ್ಲಿ ಆಯುರ್ವೇದಿಕ ಚಿಕಿತ್ಸೆ ಅತ್ಯಂತ ಮಹತ್ವವಾದಂತಹ ಪಾತ್ರವನ್ನು ಪಡೆದಿದೆ. ಅದಕ್ಕೆ ಎಲ್ಲ ಶಿಕ್ಷಣಗಳಲ್ಲಿ ಅತ್ಯಂತ ಶ್ರೇಷ್ಠವಾದಂತಹ ಶಿಕ್ಷಣ ಅಂದರೆ ನಮ್ಮ ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣ ಮತ್ತು ತಾಂತ್ರಿಕ ಶಿಕ್ಷಣ ಹಾಗೂ ಇಂಜಿನಿಯರಿಂಗು ಇನ್ನಿತರ ವಿವಿಧ ಶಿಕ್ಷಣಗಳಲ್ಲಿ ಬರ್ತಕ್ಕಂತಹ ಮಹತ್ವತೆಯನ್ನು ಪಡೆದುಕೊಂಡಿದೆ. ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣ ಸಮಾಜದಲ್ಲಿ ಅತ್ಯಂತ ಮಹತ್ವವಾದಂಥದ್ದು ಮತ್ತು ಜನರಿಗೆ ಕೊಡ್ತಕ್ಕಂತಹ ಸೇವಾ ಮೌಲ್ಯವಾದಂತಹ ಒಂದು ಸೇವೆ. ಅದಕ್ಕೆ ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣ ಏನಿದೆ ಎಲ್ಲರೂ ಇಚ್ಛೆ ಪಡುವವರು, ನಾವು ಕೂಡ ಇಚ್ಛೆ ಪಟ್ಟಿದ್ದೀವಿ, ಆದರೆ ಕಲಿಯೋಕ್ಕೆ ನಮಗೆ ಆಗಲಿಲ್ಲ. ಯಾಕಂದರೆ ಆವಾಗಿನ ದಿನಮಾನಗಳಲ್ಲಿ ಇನ್ ದಿ ಇಯರ್ ಆಫ್ 1992-93 ನಮಗೆ ಈ ಶಿಕ್ಷಣ ಸಿಗಲಿಲ್ಲ. ಅದಕ್ಕೆ ನಾವೇನಿದೆ ಆರ್ಟ್ಸ್ ಸೆಕ್ಷನ್ದಲ್ಲಿ ಹೋಗಿ ಕಲೆಯನ್ನು ಕಲಿತು, ಮಾತನಾಡುವ ಕಲೆ ಮತ್ತು ಅಡ್ಮಿನಿಸ್ಟ್ರೇಷನ್ ಕಲೆಯನ್ನು ಕಲಿತು ಒಂದು ಆಡಳಿತಗಾರರಾಗಿ ನಾವು ಸೇವೆ ಸಲ್ಲಿಸ್ತಾ ಇದ್ದೀವಿ. ಆದರೆ ಸಮಾಜಕ್ಕೆ ನೇರವಾಗಿ ಜನರಿಗೆ ಅನುಕೂಲವಾಗುವಂಥ ಸೇವೆ ಮತ್ತು ಜನರಿಗೆ ಒಳ್ಳೆಯ ಚಿಕಿತ್ಸೆಯನ್ನು ಕೊಡ್ತಕ್ಕಂಥ ಸೇವೆ, ಜನರನ್ನು ಆರೋಗ್ಯದಿಂದ ಕಾಪಾಡುವಂಥ ಸೇವೆ, ಸಮಾಜವನ್ನು ಆರೋಗ್ಯ ದೃಷ್ಟಿಯಿಂದ ಇಡ್ತಕ್ಕಂಥ ಸೇವೆ, ಈ ಎಲ್ಲ ದೃಷ್ಟಿಯ ಸೇವೆಗಳನ್ನು ಮಾಡೋದಂದರೆ ನಮ್ಮ ವೈದ್ಯಕೀಯ ರಂಗ ಮಾತ್ರ. ಅದಕ್ಕೆ ಹೇಳ್ತಾರೆ, ಮೊದಲಿಗೆ ನಾವೆಲ್ಲ ಸಣ್ಣವರಿದ್ದಾಗ ಒಂದೇ ಒಂದು ರೀತಿಯಾದಂಥ ಔಷಧಿಯನ್ನು ಕೊಡ್ತಾಯಿದ್ರು. ನೀವು ನೆಗಡಿ ಹೋದ್ರು ಅದೇ ಔಷಧ ಕೊಡ್ತಿದ್ರು, ಕಾಂಪೌಂಡರು ಬೇರೆ ಯಾರು ಹೋದ್ರೂ ಒಂದೇ ಔಷಧ ಕೊಡ್ತಿದ್ರು ಅಷ್ಟೇ. ಅದು ಏನು ಒಂದು ಬೇರೆ ಒಂದು ಬಾಟ್ಲ್ ತೊಗೊಂಡು ಹೋಗ್ತಿದ್ವಿ, ಆ ಬಾಟ್ಲಲ್ಲಿ ಕೊಡ್ತಾ ಇದ್ವಿ. ಅದು ಭಾಳ ದಿನದಲ್ಲ, ಈಗ ಒಂದು 50 years ಬ್ಯಾಕ್. ಬರ್ತಾ ಬರ್ತಾ ಏನಾಯ್ತಂದರೆ ತಲೆನೋವಿಗೊಂದು ಬೇರೆ ಗುಳಿಗೆ, ಆಮೇಲೆ ನೆಗಡಿಗೊಂದು, ಹೀಗೆ ಬರ್ತಾ ಬರ್ತಾ ಬೇರೆ ಬೇರೆ ಟ್ಯಾಬ್ಲೆಟ್ಸ್ಗಳನ್ನ ಅಲೋಪತಿಗಾಗಿ ಕೊಡ್ತಾಯಿದ್ರು. ಆಯುರ್ವೇದಿಕ ಅತ್ಯಂತ ಸಾವಕಾಶವಾಗಿ ಆರಾಮಾಗ್ತೈತೆ ಅನ್ನೋದೊಂದು ನಮ್ಮ ತಲೆಯಲ್ಲಿ ಅದನ್ನು ಹಾಕಿ ಅವರೇನಿದೆ ಅಲೋಪತಿಕ್ಕೆ ಹೆಚ್ಚಿನ ಮಹತ್ವವನ್ನು ಕೊಟ್ಕೋತು ಬಂದರು. ಆಯುರ್ವೇದಿಕ ಅತ್ಯಂತ ಮಹತ್ವವಾದಂಥದ್ದು ಮತ್ತು ಅದು ಸ್ಲೋ ಆಗಿ ಅದು ಕ್ಯೂರ್ ಆದರೂ ಪೂರ್ತಿ ಕ್ಯೂರ್ ಆಗುತ್ತೆ. ಅಲೋಪತಿಕ್ಕು ಆ ರೀತಿ ಇರೋಂಗಿಲ್ಲ. ಆ ಮೆಡಿಸಿನ್ ಕೊಟ್ಟಾಗ ಮಾತ್ರ ಕ್ಯೂರ್ ಆಗುತ್ತೆ. ಅದರ ನಂತರದಲ್ಲಿ ಅದರದ್ದು ಪವರ್ ಕಡಿಮೆ ಆದಾಗ ಮತ್ತು ಯಥಾಸ್ಥಿತಿಯಲ್ಲಿ ಆ ರೋಗ ಬಳಲ್ತಾ ಇರ್ತದೆ ಅನ್ನೋದು ಸಾಕಷ್ಟು ಜನರಿಗೆ ಗೊತ್ತಿದ್ದಂತಹ ಮಾತು. ಅದಕ್ಕೆ ಆಯುರ್ವೇದಿಕದಲ್ಲಿರ್ತಕ್ಕಂತಹ ಪಂಚತಂತ್ರ ಆಯಿತು. ಆಮೇಲೆ ವಿವಿಧ ಅಂಗಗಳ ಬಗ್ಗೆ ತಾವು ಕೂಡ ಅತ್ಯಂತ ಸಂಶೋಧನೆಗಳನ್ನು ಮಾಡಿದಿರಿ ಮತ್ತು ಜನರಿಗೆ ಇದರ ಬಗ್ಗೆ ಹೆಚ್ಚಿನ ಆಸಕ್ತಿಯನ್ನು ವಹಿಸುವಂತೆ ಪ್ರಚಾರ ಕೂಡ ಮಾಡ್ತಾ ಇದ್ದಾರೆ ಮತ್ತು ಕಾನ್ಫರೆನ್ಸ್ಗಳನ್ನು ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಏನು ಅಲೋಪತಿಕ್ ಡಾಕ್ಟರ್ಸ್ಗಳು ಯಾವ ರೀತಿ ಕಾನ್ಫರೆನ್ಸ್ಗಳು ಮಾಡ್ತಾರೋ ಅದೇ ರೀತಿ ಆಯುರ್ವೇದಿಕದಲ್ಲಿ ಸಹಿತ ಸಾಕಷ್ಟು ಡಾಕ್ಟರ್ಸ್ಗಳನ್ನು ಕಾನ್ಫರೆನ್ಸ್ ಮಾಡಿ ಒಳ್ಳೆಯ ರೋಗಗಳನ್ನು ತೊಗಲು ಹಾಕುವ ಬಗ್ಗೆ ಚರ್ಚೆಗಳನ್ನು ಮಾಡ್ತಾ ಇದ್ದೀರಿ, ಸಂಶೋಧನೆಗಳನ್ನು ಮಾಡ್ತಾ ಇದ್ದೀರಿ. ಇದರಿಂದ ಅತ್ಯಂತ ಮಹತ್ವವಾದಂಥದ್ದು ಅದರಲ್ಲಿ ಬರ್ತಕ್ಕಂಥದ್ದು ಹಾರ್ಟ್ ಮತ್ತು ಹೃದಯ ಹಾಗೂ ಯಕೃತ್. ಮನುಷ್ಯನಲ್ಲಿರ್ತಕ್ಕಂಥ ಈ ಅಂಗ ಏನಿದೆ ಅತ್ಯಂತ ಮಹತ್ವವಾದಂಥ ಅಂಗ. ಹೃದಯದ ಬಗ್ಗೆ ಆಯಿತು, ಎಲ್ಲದರ ಬಗ್ಗೆಯೂ ಸಾಕಷ್ಟು ಸಂಶೋಧನೆ ಮಾಡಿದಿರಿ. ಯಕೃತದ ಬಗ್ಗೆ ಸಹಿತ ಸಂಶೋಧನೆ ಮಾಡ್ತಾ ಇದ್ದೀರಿ. ಯಕೃತ ಏನಿದೆ ಅದು ಮಾನವನಲ್ಲಿರ್ತಕ್ಕಂತಹ ಒಂದು ವಿಶಿಷ್ಟವಾದಂಥ ಅಂಗ. ಅದೇ ಪಚನ ಕ್ರಿಯೆಯನ್ನು ಮಾಡ್ತಾ ಇರೋದು, ಅದೇ ಪಿತ್ತ ಜನಕಾಂಗವನ್ನು ಕೊಡ್ತಾ ಇರೋದು ಮತ್ತು ಜನನ ಆರೋಗ್ಯವನ್ನು ಒಳ್ಳೆಯ ದೃಷ್ಟಿಯಿಂದ ಇಡಬೇಕಾದ್ರೆ ಯಕೃತ ಅತ್ಯಂತ ಮಹತ್ವವಾದಂಥದ್ದು ಅನ್ನೋದನ್ನು ಈಗ ನಮ್ಮ ಆಯುರ್ವೇದಿಕ ಶಿಕ್ಷಣದಲ್ಲಿ ಕೊಡ್ತಾ ಇದ್ದೀರಿ. ಅದಕ್ಕೆ ಯಕೃತದಿಂದ ನಾವು ರೋಗದ ಯಕೃತಿಗೆ ಬರ್ತಕ್ಕಂಥ ಹೈಪಟೈಟಿಸ್ ಆಯಿತು ಅಥವಾ ಕ್ಯಾನ್ಸರ್ ಆಯಿತು, ಇನ್ನಿತರ ರೋಗಗಳಿದ್ದರೆ ಆ ರೋಗಗಳನ್ನು ಯಾವ ರೀತಿ ತಗುಲಿಸಬೇಕು, ಅವುಗಳನ್ನು ಯಾವ ರೀತಿಯಾಗಿ ನಾವು ಕಡೆಗಣಿಸಬೇಕು ಅನ್ನೋದ್ರ ಬಗ್ಗೆ ಅತ್ಯಂತ ಮಹತ್ವವಂತಹ ಒಂದು ಸಂಶೋಧನೆಯನ್ನು ಮಾಡ್ತಾ ಇದ್ದೀರಿ ಮತ್ತು ಎಲ್ಲ ವೈದ್ಯಾಧಿಕಾರಿಗಳು ಕೂತ್ಕೊಂಡು ಅದರ ಬಗ್ಗೆ ಚರ್ಚೆ ಮಾಡ್ತಾ ಇದ್ದೀರಿ. ಚರ್ಚೆ ಮಾಡಿ ಒಂದು ಒಳ್ಳೆಯ ನಿಮ್ಮ ರಿಸಲ್ಟ್ ಬರಲಿ ಅಂತಕ್ಕಂಥದ್ದನ್ನು ನಾನು ಹೇಳ್ತಾ ಇದ್ದು ನನ್ನ 2 ಮಾತುಗಳನ್ನು ಮುಗಿಸ್ತಾ ಇದ್ದೀನಿ. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್.
ಥ್ಯಾಂಕ್ ಯು ಸರ್. ವೈದ್ಯಕೀಯ ವೃತ್ತಿ ತಗೊಳ್ಳಿಕ್ಕೆ ಆಗಿಲ್ಲ ಅಂತ ನೀವು ಹೇಳಿದ್ರಿ, ಆದರೆ ನಮ್ಮಂಥ ಎಷ್ಟೋ ವೈದ್ಯರಿಗೆ ಒಂದು ಸುಸ್ಥಿತಿಯನ್ನು ಉಂಟು ಮಾಡ್ತಾ ಇದ್ದೀರಾ, ನಮ್ಗಿಂತ ಒಂದು ಹೆಜ್ಜೆ ಮುಂದೆ ಇದ್ದೀರಾ ಅಂತ ಹೇಳ್ತಾ ತಾವು ಬಂದಿದ್ದಕ್ಕೆ ತುಂಬ ಹೃದಯದ ಧನ್ಯವಾದಗಳು ಸರ್.
Now I request Dr. N.A. Magdum, President SGS Sankli, to render his presidential speech.
Good morning, everybody. Respected dignitaries on the dais, Honorable Sri Subhash Sampagavi sir, and all the dignitaries on the dais, all principals, faculty members, dignitaries, resource persons, and researchers, and PG scholars and media students. It is really a high time to go for such kind of conferences. As you all know, today the situation in the globe, because of the human beings' lifestyle diseases, what we call nowadays liver diseases especially, are very high in percentage comparing to the past. That could be because of our lifestyle or of food or whatever may be. The thing is, we have at this stage, for this kind of diseases, we should find out some integrated system of approach so that we will get the solutions, very good solutions for that. As there is a limitation in the field of medicine, maybe in Ayurveda or maybe in allopathy. There is a limitation of their own. For Ayurveda, we have got our own limitations. For allopathy, they have got their own limitations. So, if the combined approach is there, if the integrated approach is there, then we can find a better solutions than this. That is why our intention to organize such a conferences is, let us go for an integrated way of approach for the treatment. Anyhow, our motto is to give the best treatment to the patient, best result to the patient. That is very important. In this angle, we are trying to, actually we are very lucky that today we have very nice speakers, resource persons. From the side of allopathy, Dr. Sujay Kulkarni is there, who is a renowned gastroenterologist from Miraj, and our other Ayurvedic speakers are there. The thing is, as we all know, today, what I feel is, in the near future, within the next another 5 to 10 years, Ayurveda will be across the globe, because the need of Ayurveda today is very, very essential. Because we, in the initial stage, initially only I told that there is a limitation for medicines of any pathies or Ayurveda. So in this angle, if we think, see, very fortunately today, the government of India has taken a very good initiation to bring Ayurveda to the mainstream, which is, we are all lucky, and our ancient science, we are bringing it to the globe, and world is accepting now. In the initially, what has happened is yoga was limited to the country, and one fine morning, yoga has been accepted by the globe. When it has been accepted by the globe, throughout the world, we started Yoga Day now. Likewise, now we are celebrating Ayurveda Day in the country. The one day will come that we will celebrate World Ayurveda Day. That is a very, very nearer future, we can celebrate that. So if we go to that, if we want to go to that level, our researches, our scientific sessions, all these things are very important, so that with the evidence we can show the world that our Ayurveda has got this kind of treatment, this kind of system, this kind of medicine. This system has got its own way. Because everybody knows we are all Ayurvedic physicians or Ayurvedic doctors, or principals, faculty members, students are here. We know about Ayurveda. Ayurveda not only, it's not only the way of treatment. What we can say is it is a lifestyle. See, if you accept the Ayurveda lifestyle according to the Ayurveda, there should not be the disease as we can think. So in this angle, these kind of conferences are very, very important and essential. And for the development of Ayurveda, such kind of international, national, international conferences are very, very essential. And as the dream of our principal is, next year anyhow we are going to shift in the new premises, and there we are planning to go for an international conference in our new premises. That's what we are expecting. And I'm very happy that delegates, not only from the Karnataka state, many other states like Maharashtra, Kerala, Gujarat, many other state delegates have been participating in this conference. It's very positive finding. And the thing is, the present paper presentation and all the things whole way, whatever you are doing, from our side, from the management, from the principal, we wish you all the best. And lastly, I wholeheartedly thank to Sri Subhash Sampagavi sir for our request. He has participated in this conference, and he has done the inauguration of this conference. Really, sir, from our institution, our Gomtesh Education Society, we are thankful to you, sir. And at this juncture, for giving me an opportunity for this international national seminar, giving me an opportunity, I am very much thankful to you. Thank you, one and all. Thank you.
Thank you so much, sir. It's a fortunate to work under your guidance. It's all happening because of your support. We all are very grateful to you. Thank you, sir. Now, as we come to the end of our inaugural function, I would like to express my sincere gratitude to everyone who made this event as a beautiful start for upcoming scientific sessions. I extend my sincere thanks to Sri Subhash Sampagavi, Assistant Commissioner, Chikkodi. Thank you, sir.
On behalf of Team Yakrit Sanjeevini, we express heartfelt thanks to today's guests, Dr. Ashok Kulkarni sir, MD Medicine, Miraj. Thank you, sir. Thank you, Dr. Vinay Mohan sir. He's a principal from Inchil College. So thank you so much, sir. I also thank Dr. B.Y. Ganti sir, principal, Harugiri College, for your presence. Thank you, sir. On behalf of Team Yakrit Sanjeevini, we express heartfelt thanks to Dr. N.A. Magdum. He is a president of today's function and president of Sri Gomtesh Education Society, Ankli. In the absence of Dr. Harshavardhan N. Magdum, sir, Vice President, and Srimati Lalita N. Magdum, Madam, Treasurer of Shri Gomtesh Education Society, Ankli, I extend my heartfelt thanks to them. I extend my thanks to Shri Suresh B. Chaugule, sir, Secretary of Shri Gomtesh Education Society, Ankli.
I take this opportunity to thank Dr. Prasanna Savanur, Principal, SGS Ankali, and Dr. Ramgonda Patil, Vice Principal, SGS Ankali, and Dr. Sujay A. Kulkarni, MD Medicine, DNB Gastroenterology, Meerut.
I extend my thanks to the organizing secretaries, Dr. Vishal Chavgule, organizing secretary, head of the department, Department of Panchakarma, and Dr. Pankaja Savnur, madam, organizing secretary, head of the department, Department of Kaya Chikitsa, for joining your hands to this inaugural function. I also thank special inviting all the teaching faculties and non-teaching staff, delegates, students, media friends, supporting for photography and the audio visuals. Thank you one and all. Very shortly, we're going to start the first scientific session. We have first scientific session by Dr. Sujay A. Kulkarni, sir, MD Medicine, DNB Gastroenterology, Meerut.
gastroenterologist from here. So before begin its session, so please occupy the stage. Before to begin with the session, let me introduce our today's resource person, Dr. Sujay Ashok Kulkarni, sir. Sir is a renowned gastroenterologist. Presently, sir is consultant gastroenterologist at Ashok Kulkarni Hospital, Meerut, and also honorary
consultant at Ushakal Abhinav Institute of Medical Sciences, Sangli. Also, sir is an expert visiting panelist of our Dr. N. Magdum Hospital for all the gastroenterology cases. Sir has completed his post-graduation in medicine from Baroda Medical College, Vadodara, Gujarat. Later, sir pursued his super specialty from prestigious institute, Asian Institute of Gastroenterology, Hyderabad, and also honored with DNB in gastroenterology under Padma Shri, Padma Vibhushan, Dr. Nageshwar Reddy sir. Presently, sir is having working skills with expertise in diagnostic and therapeutic endoscopy, operating more than 10,000 upper GI cases and more than 5,000 lower GI colonoscopies. And along with other, within last 4.5 years, sir has performed more than 8,000 endoscopic procedures, including ERCPs and other endoscopy procedures. We are honored to have you, sir, on this platform, Yakrit Sanjeevini 2025. On behalf of the team of this Yakrit Sanjeevini 2025, I welcome you, sir. And before that, I kindly note, delegates kindly note, the presentation will be for 40 minutes, followed by 20 minutes of interactive session. So kindly proceed with the presentation, sir. Over to you, sir. Thank you. Meanwhile, the delegates can, during interaction, you can pass any questions through any chits provided to you, and also in your WhatsApp group, any queries, anything, any questions you can put in that WhatsApp group. Soon after session, there will be interaction. Over to you, sir.
Am I audible? I'm humbled by the number of audience I have seen. I mean, it's a great, I should congratulate all the organizers. I know N.A. Magdum sir since I was a child, but I think the institution has grown beyond its limits. And the team, whatever sir has created, has done a great job. Looking at you, I can understand it. Slide. When I look at you, I remember my old days in college days. Most of the colleges where I learned, there was no campus at all. So it was a hospital and the college was attached to hospital. So it was for a campus, for any college going student, a campus requires a college and resting something, a small resting place and classrooms. But for medical colleges, most of the times, this is not the case because most of the colleges, they are nearby hospital or inside hospital campus. So whenever you are out of your classroom or out of your clinics, you see not your colleagues, not your friends, you see only patients. So you are fortunate to have such a great campus, which we do not have. We never, our campus is all inside hospitals. But this is a very nice campus, and you have very nice facilities. We learned in government hospitals, government medical colleges, at that time, this kind of halls and facilities and projectors were not there. So you people are very lucky and should thank any of those for creating such a facility for you. So we'll start with this topic. Many of the speakers before me were told that liver, why this is important, why diseases are, why liver is making more noise in recent past days. Because liver is something related to lifestyle. Whether it is alcohol, whether it is obesity, all those things which cause liver disease are related to lifestyle. So lifestyle is changing. 20, 25, 30 years back, this kind of word was not there in textbooks. But since last 15, 20 years, this is making more headlines. And now in West, this disease is surpassing alcoholic liver diseases. So that's why this topic I chose. What we all know is liver means alcoholic liver disease. But I think though it is worldwide most common cause, still in India, alcohol tops the list. Non-alcoholic fatty liver disease affect a quarter of global adult population. This is not a small number. It's a very, very big number. And is the second leading cause of end-stage liver disease and liver transplantation in Europe and America. And we are following the same trend. We are following their own lifestyles. As the country becomes more affluent, people become more obese, more fatty, and then we have the same trend. Whatever diseases they were there 20, 35 years back, more common in Western population, same diseases are coming to India. You have seen, I mean, my teachers used to tell me that if during their DM gastro exam, if they utter a word of Crohn's disease, they used to get failed. But in nowadays, we get so many Crohn's diseases because at that time, Crohn's disease was virtually non-existent in India. But as lifestyle changed, as we followed westernized diet, those we followed their diseases also. The most important irony of our country is we have our own prior burden of infectious diseases and the pre-existing burden of other diseases, plus as we follow Western diet and Westernized lifestyle, diseases regarding burden of those lifestyles also increase. So we are facing dual burden of diseases. So still topping the list, alcohol, but non-alcoholic fatty liver disease is slowly progressing and increasing worldwide. So you can see the prevalence has crossed 30%, and the percentage of total deaths related to non-alcoholic fatty liver disease have almost doubled in last 1 decade. So it's the second leading cause of liver transplantation and leading cause. Most importantly, it is a very important cause of liver disease in females. It's not autoimmune disease, it's NFLD. And metabolic risk factor, important thing is these changes start at very early in life. So whatever this process of liver getting metabolically changed and to form cirrhosis, it takes decades. It's not a disease of years. So it takes decades and the process starts very early in the life. So childhood obesity and adolescent obesity, and that is those things which are important as far as metabolic associated fatty liver disease is concerned. And importantly, these are preventable things. If you have good eating habits from the beginning, then probably you can prevent these diseases. So prevention is very much possible in these kind of things if we have a proper attitude in understanding those diseases. So recently there is in last say 4 to 5 years, the nomenclature is changing. Previously it is called as, we know alcoholic liver disease, then we know that something else is also causing a fatty liver disease. So that's why what they called it as a non-alcoholic fatty liver disease. And slowly in last 4 or 5 years, this terminology is changing to metabolic associated steatotic liver disease. Why? Because they want to focus on the metabolic dysfunction, which is slowly causing liver damage. And that is responsible rather than in case of alcohol, where it's a more rapid process of liver damage. So this is a very slow process. Metabolism is the central part. Obesity and insulin resistance is the key. These are the key things, and that they wanted to focus. And they also wanted to include other steatotic metabolic associated steatotic liver disease under one umbrella. So that's why the name changed from NFLD. Now, if you see research papers, NFLD you will see less. Say maybe 10 years back, NFLD was more common term, but nowadays MSLD is the more common term. So I'm henceforth in the whatever talk, we will refer it to MSLD. So somebody was talking about worldwide prevalence because of the changing scenario of our eating, our habits. And you can see in even our country is not left behind as far as these things are concerned. Slowly obesity and prevalence of insulin resistance and NFLD is increasing. So we all know we have a huge population, probably the #1 populous country in the world now. And any country which is number one in population will have number one in all diseases. So as far as concerned, probably the most number of diabetics are in India now. We have the maximum number of diabetic people, and if you pool the prevalence, then the NFLD prevalence will cross 35% in our country. And it is more higher amongst diabetes, obese, and those who are having metabolic syndrome. So these three are the people to whom you should screen for metabolic associated steatotic liver disease, because most of them are asymptomatic. As far as liver is concerned, they are asymptomatic. They might be having other symptoms of diabetes, obesity related, they might have heart disease, they might have some kidney affection, but they don't have liver symptoms. You have to screen them. So you have to identify high risk population and screen them. So this is one study which I can quote. This for as far as epidemiology of metabolic associated liver disease in India is concerned. This is called as MAP study, a landmark study. And this study was aimed to assess the prevalence and severity across Indian regions using FibroScan. And for those who don't know about FibroScan, it's a what you can say, it sends vibration and ultrasonic waves inside the liver, and as they travel, they measure the elasticity of the liver. As liver becomes more fatty, more fibrotic, the elasticity of the liver goes down, and you can grade that liver based on the steatosis, that is fat, and fibrosis, and that is how you calculate different values. And depending on these values, they have mapped India and seen the severity and prevalence. So it was 68.2%. It's not a small number, it's a very big number. The sir was sitting here. I think the government should consider and take note of these things, because this is going to be the next epidemic in India, not the COVID. So with the highest burden in North India, reaching up to 73.2, and severe fibrosis most common in Kerala. So you can see these are the numbers. So F0 to F1, these are different grades, F0, F1, 2, 3. I have marked our two states in this Karnataka and Maharashtra. As far as steatosis, the S0, S1 is fat, F1, F2 is fibrosis. So it provides two kind of grading as far as fat and steatosis is concerned. And these are our, this graph indicates where our states stand. More or less, it is a matter of concern one should address. So why this topic for you? This is very interesting study. So to explore the epidemiology and awareness, what they did is they went into medical colleges and they just took the data from the medical student itself. So the health prevalence science program, during only undergraduate students were involved across from the all 30 to 40 medical colleges they were considering. 7.5% prevalence of MSLD was present in medical student itself. And most importantly, they were unaware of these things. So this gap between their understanding of the disease characteristic and implication and actual testing and diagnosis rates were quite low. And this lecture is for that, to bridge this gap, to make you aware of this coming epidemic. So that's why particularly I chose this topic. Now coming to the diagnostic criterion, I already told you most of these people are asymptomatic. So you have to identify, most of these people will come to you right upper quadrant pain. They may have obesity, they may have metabolic syndrome, diabetes for so many years. And then you will feel they may fit into these cardiometabolic criteria. You have BMI, you have fasting blood glucose, blood pressure, triglycerides, and cholesterol, and so on and so forth. So if patient satisfies these criteria and patient satisfies the radiological criteria of steatosis, usually we can diagnose metabolic associated study of MSLD very quickly. It doesn't require a rocket science. So very simple criteria has been provided to diagnose. Not every patient requires liver biopsy. So I don't know how much pathology or pathophysiology is there in your syllabus, but this is how things take place. Pathogenesis itself is a very big topic as far as NFLD is concerned, but in one shot, if I want to call, it's the first step. It's your lifestyle. which makes you insulin resistant. And once this insulin resistance develops, liver starts gathering fat. More free fatty acids are produced, more triglycerides are produced, and all these fat, they are inflammogenic. That is what they call. And then inflammation, oxidative stress, apoptosis starts, and fibrosis starts. So up till steatosis, things can be reversible. To certain extent, fibrosis also is reversible in some diseases, but once you cross F3, F4, you are less likely to revert back. So liver is a very good organ in one sense that most of your organ or other organs, if you take myocardium, heart, or if you take brain, no recovery. Once damaged, it is damaged. No new cells, no new myocardium develops, no new neurons develop. But in liver, new hepatocyte develop. And that is what the principle of liver transplantation. What they do is in liver transplant, in a live donor liver transplant, they take half of the liver of the healthy person and they fit that liver in a deceased donor, and the half liver regenerates to a full-fledged liver and takes over the function of the body. So that much is the capacity of a healthy liver to regenerate itself to a double. When that capacity is overwhelmed by these oxidative stress, inflammation and fibrogenesis, then only cirrhosis develops. So we have a lot of room, we have a lot of time, but we should screen those people and intervene so that the disease doesn't progress. So that is very important. So this is how things took place. The same thing, metabolic syndrome, it causes insulin resistance. As I told, insulin resistance causes increased triglycerides, and this free fatty acids, these are the things. Free fatty acids are the oxidative inducing stressors. What are working against them are the antioxidants. So that's why people say a lot of antioxidants, eat a lot of fruits which contain oxidants, fresh vegetables which contain antioxidants. So what antioxidants do is to oppose these free fatty acids which are causing oxidative stress, and that oxidative stress is slowly causing liver damage. So this is, you can see lipotoxicity. I don't want to go into details, but it causes endoplasmic reticulum stress. So if you remember, the cell contains endoplasmic reticulum, and that endoplasmic reticulum contains some globular vesicles which has some lytic enzymes. And when ER is under stress, these lytic enzymes are released and they cause cell damages. Oxidative stress, I already told. Autophagy is your own cells eat your own cells, or your own cells start damaging your own cells. There is something called as stellate cell in liver, which when gets activated because of some insults, converted into a fibrogenic secreting cells and or of macrophage, and then it causes fibrosis. So that is what is responsible. Similarly, you have inflammation and lipoapoptosis. So it's a delicate balance. You have on one side forces causing liver damage, and on other side you have forces which are opposing them. So liver can regenerate, and liver is constantly opposing. So it's a battle going on inside to protect liver and to damage liver. And when this balance shifts more in the favor of liver damaging things, this is what the disease develops. So it's a very slow process. It's invisible process. Patient directly can present to you with a ascites, cirrhosis, and he says, I have never had alcohol any time in my life, but yes, I was having diabetes for 20 years, and my weight was more than 90 kg, and BMI was 28, 29. He must be having a liver disease. So what are the risk factors? These are things, environmental factors in the form of sedentary lifestyle, lack of exercise is a routine now, and high calorie diet. You know, I mean, somebody told me that the Fanta what we drink in India has more sugar than Fanta which is sold in Europe. Even the government must know the standard for any liquid being sold. The European standards of having sugar are different than the Indian standards for having sugar. So our government, whatever the authorities which are destined to make laws for this, they have to be very careful while allowing these cold drinks makers or other, I mean, all these whatever food we eat, whatever cold drinks we drink, how much sugar content it should have. So that is very important. Even some people have shown a slide where whether the color of the Fanta in India and the color of the Fanta in Europe was a different. So those countries have developed got sensitized to that much extent that they have made laws against it to prevent these diseases. So this is very important. So demographic factors, age and gender. If you are born in an affluent family, you have been spoon fed nicely throughout your life since the beginning, you tend to become obese throughout you. It's the number of fat cells once you develop. During your growth, number of fat cells increases. Once your growth is complete, the number of fat cells remains same. Only their size increases. So during your growth, if you take more and more food, already you have lot of fat cells inside you. You can reduce your weight, you can reduce their size, but number is constant. So during childhood, unnecessarily extra feeding is not warranted. Slowly, India has moved from 70s to now in 2025. The 70s in India, there was a famine, there was a drought, people were malnourished. In even 2025, we are still malnourished, but the pendulum has shifted from lower nourishment to the higher nourishment. And these things are needed to be addressed by the government. Genetics and ability, there are certain genes, I don't want to go into details, PNPLA3. Not every obese person develop these diseases. Why certain people only develop liver disease is because of the underlying genetic issues. So there are certain genes like PNPLA3 which are responsible for liver disease even in non-obese patients. And you have metabolic syndrome, as I told you, it's a part of your lifestyle, that is type 2 diabetes, hypertension and lipid disorders. Another most important part is in all GI cases, now gut microbiome is playing an important part. You can imagine the intestine is the largest immune organ in the body, which harnesses microbiome number. The number of bacteria which are present in your gut are more than total number of people living on the earth. So you can imagine we are harboring hell number of bacteria and we are in good terms with them. We are in symbiotic terms with them. So when this symbiosis is lost, when there is some kind of quarrel between us and them, then diseases happen. And this is told by Ayurveda long back, said when there is an imbalance between the internal homeogenesis, you get a disease. So same thing allopathy is telling now, that there is a balance in the body, with the body and the organisms what we have, and when that balance is lost, most of the diseases occur. So whether it is inflammatory bowel disease, whether it is any other disease, some people are saying even Alzheimer's disease is now caused, is having some role because of the gut microbiome dysregulation. So this gut microbiome dysregulation, what it does is, it stimulates the immunity. Gut microbiome is an antigen. So when that antigen is friendly with your body, your immune system doesn't recognize it as a foreign and allow him to stay there. But when the immune dysregulation occurs, your body recognizes that protein of that particular bacteria or virus as a foreign, and when that protein is being identified or a similar protein is found in the liver, the cells or the immune system gets activated and attacks liver. So wherever such kind of protein or similar proteins are found, those things get attacked. And that is how the immunity or the gut microbiome dysregulation helps in formation of various diseases, including the liver disease. Clinical features, I think most of them are asymptomatic, as I told you, and sometimes they directly present to you with a decompensated liver disease. This is one kind of presentation, and few may present to your OPD with the right upper quadrant pain, may have mild hepatomegaly, and USG may show, say, grade 2-3 fatty change, and the transaminitis, say SGOT, SGPT may have, say, mild transaminitis in the form of 2 to 3 times. You have SGPT, SGOT values of 40 international unit as an upper limit of normal. So anything 2-3 times, 4-5 times. So that is how we measure 2-3 times, 4 times, 5-6 times, 10 times elevation. So you have mild elevation in the form of 2-3 times, 4 times, and that may indicate an ongoing liver injury. And I mean, no, none of them require an admission. But yes, all of them require evaluation because this is how the disease progresses. This is healthy liver, completely fat-free. So over a period of say 6, 8, 10 years, 10 to 12 years, slowly it develops into a fatty liver. A fatty liver, that means 50 to 30%. So this requires a hell lot of time. Then within next 4 to 5 years, say 12 to 40, up to 40%, as you can see the number increases as we go progresses. This same steatosis becomes NASH. NASH is metabolic associated steatohepatitis. So hepatitis, that means inflammation starts. And when this inflammation starts, every inflammation will have some cost to bear in the form of fibrosis. And when this fibrosis overwhelms the capacity of liver to regenerate, what we see is a cirrhosis. 5% of these cirrhotic patients develop HCC over a period of 10 years. So that's the process, that's the pathogenesis and the patient journey of this metabolic associated liver disease. Factors we already saw: genetic factors, environmental factors, and complications. So as diseases, once you know the disease is there in place, what are the mortalities? What are the causes of mortality as far as this disease is concerned? We all know alcoholic liver disease present to you. What are the causes of mortality? Patient may bleed, patient may go into encephalopathy, patient may go into renal failure, and so forth. Very common. Liver disease, these are the causes of mortality. But in this liver disease, you can see the cause of mortality is cardiac rather than liver related issues. And even if you take malignancy as a cause of mortality, here it's not hepatocellular carcinoma, it's the other kind of malignancies. So this kind of, it's a whole syndrome. We don't look at as a liver disease only. It's a whole syndrome going on inside your body where obesity, overweight, and insulin resistance is making changes in hell lot of organs, and those organs are also getting affected, and people are dying because of those reasons. So that is why MSLD has to be looked by government as a important tool where it can intervene and reduce the burden on healthcare system, so that preventing mortality as well as preventing morbidity is important. When a few years back in Beijing, people visited Beijing for Olympic inspection. Before giving any country to a right to hold Olympics, a committee visits that country or that city. So when they were visiting Beijing, somebody noticed that we have big boards, big hoardings, and advertisers in our country. Like you have advertise of a big Burger King, you have advertisement of a McDonald's, you have advertisement of a Coca-Cola or Fanta. So in our country, the advertisements are of drink and eat unhealthy food. But in China, at that time, when Beijing Olympics were being conducted, the advertisement were eat green leafy vegetables, eat fresh fruits. So that kind of government is taking so much. If you go into China and see them, most of the Chinese are thin people. Most of the Japanese are thin people. So what they are eating, why this epidemic has not percolated into East as compared to West, but it has percolated to India. Why? Because people are not aware of their lifestyle. Even government is not aware of this epidemic coming. So this is most important thing. So if you attach all these mortalities to this NFLD, then you will realize that it's not only a metabolic associated liver disease, it's a metabolic associated disease of entire system, and that needs to be corrected. So if you address MSLD, probably you are going to address all those causes of mortality. How one should approach initially, a patient coming to you, you must know his comorbidities, his diabetic status, his blood pressure status, whether adequately controlled or not, how much obese he or she is, whether he is having any other obesity-related issues like cardiovascular disease, obstructive sleep apnea, renal issues. Then the things come to liver specific, whether he has any decompensation in the form of ascites or something else, portal hypertension, look for varices. Then if you find varices, he is already a cirrhotic person. What is his medication intake? What medications he is having? And details of alcohol. So what is in one shot, if I tell you this 30 ml whiskey is equal to 100 ml wine is equal to 240 ml of beer is equal to 10 gram of alcohol. And now to have a cutoff, it's not that something who is alcoholic, that was the main issue. Alcoholic fatty liver disease is held together a different segment, and a non-alcoholic fatty liver disease, what we are talking here. So how to differentiate? Can an alcoholic person have a metabolic associated study of liver disease? Yes, and now they even say that you can have both. You can have alcoholic component also, and you can have metabolic component also. A person can be obese, can be diabetic for 20 years, and can have alcohol. So he has both the things, and his liver disease will accelerate faster. So what is the cutoff? Where can you say that metabolic associated liver disease is this, and this is not alcohol? So for cutoff for that is 30 gram of alcohol per day or 200 gram of alcohol per week. So if the person is having less than this, he's having fatty liver disease and other signs of features of liver disease, you can label him as metabolic associated liver disease. If his alcohol intake is more than this, then probably you have to label him as alcoholic fatty liver disease and not metabolic associated liver disease. So this is very important. Then you have anthropometry, you must measure the weight, hip, BMI, and nowadays waist to hip ratio, which is more important. It's not BMI, mind you. It's the waist to hip ratio that is more important. And how the fat is distributed. How much, is it a male pattern fat, a female pattern fat, a potato or tomato? These are the words now being routinely used as far as clinical research journals are concerned. So what is his blood pressure? And what are the clinical features of insulin resistance apart from obesity? You will get acanthosis, you have skin tags, you have dorsocervical fat pads. So these are signs of insulin resistance. And of course, the overt features of chronic liver disease in the form of pedalidema, ascites, so on and so forth. So what lab investigation you will do? It's a very simple thing. These lab investigations are available even at taluka places. So you can get a CBC done, LFT, sugar levels, HbA1c, lipid profile, creatine, urine albumin to creatinine ratio, and Hep C. Why Hep C? Hep C also causes fatty liver disease, but it's not the metabolic one. It's a viral related fatty liver disease. So that is also very important. So fatty liver disease is a big term. Metabolic associated fatty liver disease is a subgroup, and under metabolic associated fatty liver disease, there are many groups. So this is how things can be classified. This is again very important thing. You have USG available now I think even beyond taluka level. So easily available, practical, and I think not much expensive also. It's accurate for steatosis once you cross 30%. Okay, you can grade it also. Grade 1, 2, you must have seen those reports, grade 2 fatty liver, grade 3 fatty liver. So that is very important. Most important thing is sensitivity is not that much to detect it. And it's an operator dependent. It's a suboptimal. If you have very obese patient, you cannot, for fatty liver kind of thing, it's not very useful when you have extremely obese. Now this is elastography. VCT is vibration controlled transient elastography. So that is what we do is, they conduct those vibrations throughout the liver, and they measure the cap value. So this cap value, if it is 274 decibel per meter, then the sensitivity is more than 90%. And it can detect even milder steatosis. That is very important. And some idea about liver stiffness also it is provided. So that is LSMN, that is an index of fibrosis. So accuracy is limited when grading is concerned. And of course, this is also similar to USG. It looks very similar to USG. The probe is similar and operator dependent also. So you have to train the person nicely. Only thing is, VCT doesn't require radiologist. Even a technician in hospital can perform. While USG requires radiologist and PCP NDT and hell lot of acts. Then you have CT also. Just take the film and see whether how is your liver and spleen look like. If the attenuation of the spleen is very much to the liver, then you may have steatosis. But of course, for fatty liver, doing CT is not justifiable in a country like India. Then you have proton, MR proton density fat fraction. This is only restricted to big cities up till now, and its most accurate issue is the cost and limited availability, and predominantly in research setting, it is still being used. These are very practical things. I want this slide is the most important slide in this discussion. You have non-invasive assessment for this MSLD by doing few tests. So FIB4 contains what? It requires age that you have already. It requires AST, platelets, and ALT. That's it. So you just can have calculate this risk. Calculators are available, and 1.3 to 2.67. So that is how you can predict the patient, whether patient is having MSLD or not. Then you have APRI, that is AST. What you require is AST, platelet, and the rise in AST. So rise in AST above baseline, and then you have platelets. So that also can provide you some idea regarding whether your DC patient fits. I mean, this patient requires further testing for MSLD or not. At least that much you can guide. The most authentic is among all of these is NFLD fibrosis score. So that is NFS. What it contains is age, BMI, whether patient has diabetes or not. To be precise, insulin resistance or not, because what they measure is fasting insulin. And then AST, ALT, platelet, and albumin. So these are the things. Indirect, it is the best biomarker available as far as our country population is concerned, easily available. So not accurate in younger adults and severe diabetes and severely obese. Of course, any deviation beyond 2 standard deviations, the things may not fit for any formula. Yes, liver biopsy is the gold standard, no doubt about it. But for doing liver biopsy in a young female suspected of having autoimmune hepatitis to give steroids is something different, justified. Or a young male suspected of having Wilson disease and you are doing liver biopsy, justified. But for an OPD patient who has just come for a right upper quadrant pain and a mild transaminitis, SGPT of 100 and 125 and 250 SGOT, you are puncturing his liver, he will not come to you. So it's not justified to puncture everybody's liver just to diagnose a fat in the liver or to estimate a fat in the liver. So role is only limited to when you are not sure whether his fibrosis is, whether his steatosis is because of the metabolic issues or whether it is hepatitis C related steatosis. So when the conditions are dicey, when things are not matching what you are suspecting, when non-invasive methods are giving discordant results, at that point of time, you may embark on liver biopsy, not in every case. So this is how one should approach in patient with MSLD. You have identified a high-risk patient. He or she is having diabetes, obese, and so on and so forth, and persistently liver enzymes are elevated. You get a 5-4 test done. If it is less than 1.3, no issues. If it is more than 2.67 also, you have straightaway referral to hepatology. But somewhere if it is in between, then you can take help of transient elastography, and depending on the what value you find on transient elastography, you can follow up that patient accordingly. So this is how the guideline, that Asia Pacific guidelines suggest how to follow or how to diagnose and how to initial evaluation should be done as far as MSLD is concerned. The time being, I have to rush fast. Management mainly includes lifestyle. And then you have few liver-directed therapies. Still research is going on. We have very few drugs. And here Ayurveda probably can play an important part by inventing new and new molecules which might be helpful in preventing progression. So this is, and then assessment and optimization for insulin resistance. So these are the 3 things. Important is lifestyle changes. I don't want to go into details. You have the weight loss goals for MLC with different guidelines, European, American, Asia Pacific, even Indian National Association of Study of Liver Disease has many guidelines. Going into details will be beyond the scope of this lecture. What I want to focus is weight loss goals, recommendation as far as diet, physical activity, lifestyle habits are concerned. And the main issue in managing these kind of cirrhosis is you have to maintain any kind of cirrhosis, you lose protein. Once cirrhosis develops, you might have seen patients losing their arm girth, their thigh girth, their muscle mass. So muscle mass starts going. So you have to give them nutrition also, but at the same time, you have to see that the insulin resistance does not worsen. So that is a challenge in these kind of patients. So that is very important. So lifestyle should be adapted to the severity of liver disease and nutritional status. So that is very important. And then we have drugs. The initial two, the blue squares, these drugs are still not available in India. But what we have is semaglutide, we have liraglutide, and recently, maybe a month or two back, tirzepatide is also being approved by Indian authorities. And we have SGLT2 inhibitors like dapagliflozin, and metformin and insulin we are having for ages. And then dyslipidemia, we are using statins. And for any other syndrome like cardiovascular, renal, so on and so forth, other drugs will also come into picture. But these two I have highlighted because these are the two things which have been approved for NASH. So how GLP-1 receptor, GLP is glucagon-like peptide-1 receptor agonist. It's the receptor on which the drug acts, and that is how the effects are delivered. It slows down gastric emptying. It has many favorable effects as well. Liver, pancreas are concerned, even heart and brain. So that's why NFLD is the center of metabolism. And if you hit that area, probably you are making other organs also safer. Similarly, you have SGLT2 inhibitor. Mind you, this drug acts in renal tubules. So that's the diagram. So where the SGLT is located. SGLT is sodium glucose co-transporter. So you have a transporter, a channel, which transport both sodium and glucose molecules. So if you attenuate, if you modify that by giving some drugs, you may include the glycemic control and the whole spectrum of NFLD can be improved. Of course, both of these drugs are not considered safe once you develop decompensation. Decompensation means once you develop an overt cirrhosis, clinically overt cirrhosis, then these drugs are not helpful. There are too many guidelines, but these are the widely used guidelines. EASL is European Association of Study of Liver Disease. ESPEN is European nutrition related guidelines, and AASLD is American Association of Study of Liver Disease. So these are the guidelines which gives us how much, what kind of diet you should provide to patient with cirrhosis with MSLD. And this is very important because dietary nutrition is very, very important. You have a fatty liver, suggesting him that reduce your diet, reduce your calorie, and do exercise is very easy. But for a cirrhotic and having MASH, suggesting that reduce your diet and do exercise is not very easy. They're already weak, they already lost protein. So supplying them protein without increasing their insulin resistance is sometimes very tough. So with this, I take your leave to summarize. MSLD is having a significant burden in India. Awareness to both public and government is necessary to prevent upcoming epidemic. Pathogenesis is multifactorial and insulin resistance is central to it. Various non-invasive as well as imaging markers are available to predict, diagnose, and screen for high-risk population. And that is what India should do rather than spending money on diseases. And need to address the spectrum of metabolic syndrome along with the hepatological issue. You should not focus only on liver. That patient should be seen by a multidisciplinary team which contains cardiologists, diabetologists, so and so many people, even a nutritionist. So you have to manage that patient in entirety, not only from the liver angle. And you have to manage lifestyle, drugs, and management of the liver disease consists of management. I think it's more of having a preventive role rather than more after once you develop disease. So that is very important. I'm looking forward that Ayurveda come with some new therapies and enlighten us that how we can reduce these things. And India, as our Prime Minister says, wants to become a Vishwaguru, should become a Vishwaguru in management of NFLD by giving some Ayurvedic solutions. Thank you.
Thank you, sir. Thank you for your valuable insights. Now, the session is open for interaction. Any queries from delegates, you can put forward through the chats which are provided to you or through the WhatsApp group. Otherwise, directly you can ask.
If you have any doubts, you can raise your hand, stand up and ask the question.
On the mic.
Otherwise, we will move to the next session.
So now the session has come to end. Thank you, sir. Thank
Yes,
you
yes.
for your
Thank you,
valuable
thank you.
insights on metabolic dysfunction of associated statosis of liver disorders. Now, I request our resource person, Dr. Sujay Kulkarni, sir, to kindly accept our felicitation. I request our president, Dr. N. Magdum, sir, Dr. Ashok Kulkarni, sir, Dr. Samir Naik, sir, and Dr. Shri Suresh Chogle, sir, and Principal, sir, Vice Principal, sir, to kindly facilitate our today's resource person of first session. And also, organizing team can join the felicitation. Thank you, sir. Thank you for accepting our felicitation. And I also thank the dignitaries for facilitating the felicitation.
Thank you, everyone. And I also thank our moderator, Dr. Durdundi ji, sir.
Any queries still are welcome. Mic.
Audible? Yes. Yes, go on, go on.
My greetings, sir. Sir, the most commonly drug or the medicine they have given like Live 52, sir. Have you ever written to your patients Live 52, sir? It's like most commonly right now, sir. It is
Good
basically
question.
Ayurvedic medicine.
Yeah. But I am very naive person as far as Ayurveda is concerned. And I have seen many times written, but I don't know about the pharmacology of Ayurveda. So I have not up till now used. But yes, in future, if some publication regarding that comes in an authentic international journal, we would like to use. Although, I mean, not only Live 52, whatever medication in whatever form. Curcumin, for example, you know about curcumin?
Yes, sir.
Curcumin is what?
Haridra.
Yes, Adi. So Ayurveda has told since ages that The turmeric has to be used as a medicinal purpose in various diseases, from wound to various diseases. Now, the West is telling that you should use curcumin in inflammatory bowel disease and hell other things. So the same Ayurvedic, whatever text, they are utilizing and preventing a nicely written scientific paper, and they are presenting and they are taking the patents. So that should not happen. Where we are lacking is the research, the original research. Of course, a lot of money is required. India is not that affluent, but slowly, as we are becoming the fifth largest and fourth largest and maybe third largest economy, probably the government should spend more money on research. And once we produce our original own papers, then probably these Ayurvedic preparations will be more acceptable worldwide. What we require is, we have to pump hell lot of money. The pharma companies need to pump hell lot of money into this research. Then things can come up. Then things can be widely acceptable. To make it widely acceptable, you have to publish, do a good quality research, publish in index journals, then your research and work will be more accepted. Slowly we are moving towards that. Now India is not that behind. Our institutions like where I learned AIG, the research is on par with any European or American institute, and any new thing which comes in GI medicine or whatever in liver, that comes first in AIG, even before it is being launched in market. And slowly India is moving towards those goals. Only thing is whatever you told, these Ayurvedic preparations also need to be, you have to conduct randomized controlled trials. So RCTs are very important. RCT studies, all meta-analysis, these words should be used, and these words should become familiar as far as Ayurvedic researchers are concerned. And once you produce publication in these lines, probably your drugs will be accepted more worldwide in a more acceptable way.
Thank you, sir.
So with these words, we close the first session. Thank you, sir. Thank you for your valuable insights.
Thank you so much, sir. So now it is an announcement to the delegates. We will be having a tea break for 10 minutes to have the tea. So tea is arranged at the same area where breakfast was arranged. So immediately after 10 minutes, please gather in the conference hall, because immediately after 10 minutes, we'll start the next session, second session.
Dr. Sudhir Patil and Dr. Nimisha, please come to the anchor's dais. Dr. Sudhir Patil and Dr. Nimisha. After sharp 10 minutes, we'll be having a next scientific session. And sharp at 12:45, we'll be having parallel presentation sessions. Okay, so presenters, be ready. Once you have your tea, please occupy your seats immediately so that we can start next sessions.